All right, hello and welcome back to the Doc Buddy Journal. I'm your host, Eric. Here at Doc Buddy, of course, we deliver solutions that take the pain and cost out of broken healthcare workflows. And today we've got a really cool guest. It's Dr. Stephen Gorin. Dr. Gorin is a Miami based orthopedic surgeon and sports medicine specialist who is passionate about helping patients of all ages maintain active and healthy lives. Dr. Gorin, thanks for joining us.
Thank you for having me. I'm really excited to have our discussion today.
Oh, it's our pleasure. Good to chat with you after what feels like a really long time. And we're together today on the show. There was a couple of great takes that I saw on LinkedIn, sort of coming into the new year and out the other side into January. And our listeners will know that kind of coincides with the release of that 2025 final payment schedule from CMS. So let's start with a big question here, Dr. Gorin. What can either CMS, the government, or any payer should be doing at either small or large scale to stop finding ways to pay physicians less?
I think really the best way for them to do it would be to minimize the bureaucracy, and it kind of goes along with what we're seeing happen in government. But it's something that I think I've noticed over the years. I've been in practice now 18 years, and just noticing there's more and more steps between the patient and the care. And there's always other people that are involved where if we can get rid of a lot of the middlemen, a lot of the stuff in the middle that it gets bogs the whole system down. It's like it's like a high-speed train, and you keep throwing weight on it. It used to work nice and fast, and now you just throw more weight, and it slows it down. And it's going to get to where it needs to get, but it can't get there because we're just adding all this extra load, probably. And all that extra load puts a big burden on the whole system, not just in the office, in the hospitals, in surgery centers, anywhere. It's just the more in the middle, the tougher it is. And like everything else, we want to get healthy. The world needs to get healthier. We all need to get healthier because we're all getting bloated. Well, same thing with healthcare. Healthcare is bloated in the middle. We get rid of that, it's going to help us a lot. So really, it's that and the antiquated payment schedule that Medicare uses. I think you need to have a PhD in math to understand the reimbursement model. So come up with a much better, equitable system for everybody, and really give doctors, and I'm going to say independent doctors because I'm an independent doctor, I'm not employed. I've always been independent. Their fair share where the hospitals are actually taking a lot more, making more for the same work that we do. So I think if we're able to even out the field for everybody, would be better.
It'd be a good place to start. And before we started to record, we talked a little bit about the automated payment denial.
Yeah,
So introducing more steps to treating patients and reimbursement, obviously paying physicians less and less over time. I mean, the reimbursements are down essentially across the board. It's killing the profession. And then on
right.
top of that, there's regulation around certain health IT softwares that have to be used, which are more administration. And you've lived this. You've seen it come. It's here to stay.
So,
What can we do to improve all of these boxes that need to be checked?
it's tough because there's so many different things in the size of medicine the way it is. In a subspecialty field, which kind of focus on what we do. But when I see it with the primary care doctors, with certain insurance plans, getting referrals is at night. So a patient will show up to the office and they'll come in for their left knee, but the referrals feel bad because they had back pain a month ago, but then all of a sudden their knee got worse. They call the primary doctor, and the primary's like, they're trying to work the system. They can't work it, but by the time they get to the office, they're still the knee pain is there, but the back pain is gone, and all of a sudden we can't see them. And we want to take care of the patient, but oftentimes the patients don't understand it, and then we end up becoming explainers of the system, just like we become explainers of their insurance policies, which unfortunately the people who sell insurance don't explain to their patients and people what exactly it means to buy a Medicare Advantage program. Because oftentimes patients think they're still Medicare patients and don't realize, oh, wait a minute, I'm not a Medicare patient. I'm a Humana, I'm an AvMed. Well, simply, they think they're still Medicare patients, but they happen to have this other name. And so I think educating patients would be the best in the world, but it's got to be done by a good insurance sale. It'll be a lot less headaches, and I think that'll bring in some accountability to something I will discuss a little bit more about later. But that'll help bring accountability into the process.
Yeah, and interpreting and understanding the insurance contract you sign, whether it's through your employer or whether it's a plan that you get on yourself, you would need many attorney hours to make sense of it.
Or,
And even then, it still isn't going to totally make sense.
yeah, the insurance landscape has gotten so much more difficult over the years and so confusing for patients and even for us in the office. A lot of times I think I can do something or order something and it gets denied. And denied in my world, if I have a patient who comes in with an acute injury, and many insurances that are out there will deny, MRI just because they think that therapy is appropriate care. And it's like, I don't understand why they would rather waste 6 weeks of physical therapy, spend the money on that, have them come back to the office, and then literally just say, okay, we need to get an MRI. So too many times we get stuck with these stupid phone calls with the insurance companies. But typically, we'll see this. The Cigna is the worst one. Right? I often tell patients, if you can afford to go outside your insurance to get an MRI, go outside your insurance. Because probably with your deductible, it'll cost you less to go out of pocket than through your insurance. Plus, we can skip the 6 to 8 weeks of physical therapy because by the time you get into therapy and by the time you come back, it's going to take 2 or 3 months little process. So that's a huge issue that I see. And it puts a bigger burden on the healthcare system instead of letting us take care of the patients. I mean, imagine a patient having a heart attack. They show up to the hospital. They go, oh, no, you got to take aspirin for a month. Let's see how you do after, how you feel. You know what I mean? Because the person on the insurance side, it's just a pencil pusher. There's no the problem is they don't have any healthcare degree. You can be a high school graduate and just sit behind a computer, just follow an algorithm. And the algorithm says, oh, this is the diagnosis, this is next. They have no clue.
I was just going to say, in your example, that patient having the heart attack in the ER, take aspirin and then roll them out into the curb for the the meat wagon to pick them up.
Yeah.
And I just heard this from a guest this week, Dr. Yaft, who's a CMO at Baylor Scott and White out there in Dallas, that a lot of times these utilization review folks on the provider side may not even be in your specialty if they're a physician at all. So you might have a practitioner saying or making decisions on orthopedic cases that maybe they don't have any business doing. So how do you overcome that?
Well, what we've done in my office, that I have an excellent MA, and whenever I have to do these peer-to-peers, which patients don't even realize all the extra links we go to try to get their things approved, she'll always request for me to talk to an orthopedist because every one of these insurance companies, especially with workers' comp, and sometimes they have orthopedists on their panel. And I can say we're fortunate to deal with some of them, and they're very good at helping us understand their system. And then I'm able to talk to them. Because before I used to talk to nurses, and the nurses would just be like, well, you need therapy first. So, the patient doesn't need therapy first because they're going to get worse. They're going to get injured even further. Well, that's what the plan says. You got to do therapy first, and then we'll figure it out after. So that's one of the biggest hurdles. See it in surgery, same thing. They deny surgeries because they don't feel that it's appropriate. Because again, not a physician that's taking care of them. It's an insurance plan. That's the biggest problem.
Well, that hits at the core of what seems to be wrong with healthcare at scale in the U.S. is a misalignment of incentives. It's supposed to be a three-legged stool: the patient, the provider, and the payer. But the payer leg seems to have a lot more sway and a lot more say in some of these decisions than maybe it would in a more aligned chain.
Correct. And that's the biggest problem today with healthcare to me is the insurance companies. They become very big and powerful. They become huge money makers, and it's stronger for them. And for the rest of us who are dealing with and working on the other side of it, they add more layers and more layers that just make it bigger and tougher for us to work with.
And obviously their actuaries have it figured out, but common sense would say if you delay claims long enough for what is routine or preventative care,
Mhm.
eventually you're going to have the big whammy. Maybe it is that heart attack in the ER, God forbid.
Yeah.
At some point, that surely must cost more for the payer, but evidently not, since that's the system we're in.
Well, I think they're playing the odds. Yeah, that's that. Healthcare is just about for them. It's just about playing the odds, and they know that they'll win in the end. The house always wins, right?
Yeah, I know that better than most at
Yeah,
the blackjack table. It doesn't always go your way. Rarely goes your way.
yeah. But that's what it is. The insurance company's the house.
Yeah, that's
So
true.
we
And
don't
when
change
you
what the rules of the house. We'll never win.
and that's just it. What we started this thread on, that it's tougher and tougher to be a provider, especially to remain independent. And you see the pendulum sort of swing back and forth, or you used to see it swing back and forth between employed and independent. In the 2000s, early 2010s, it seems that pendulum is kind of stuck on the employed side. And there's
Yeah.
a lot of great independent physicians fighting the good fight, like with you and your practice. But it seems to be more and more alluring than ever to just go, I don't want to put up with all of it.
Correct.
Let me treat patients and I'll go deal with being a health system employee. What's your perspective on that?
Well, yeah. I had a discussion last night with some doctors. We're talking about it a little bit, and that's coming out of residency. The way they train today is a lot different than they trained back when I was in my training, and the attitude of the young physicians also good. And they don't want to deal with the headaches. They just want to work. Doesn't matter the field. They don't want the headaches of dealing with the office staff, credentialing, dealing with insurance companies. What I see is they think they feel it's just easier than to go work for somebody. I don't have to deal with all those headaches, and I'll just get things done. But at the end of the day, typically we go to medicine because we want to work for ourselves. We want to be our own the captain of our ship. We don't want to be on somebody else's ship getting guided whichever they want. And again, if you're an employed physician, you're an employee, which means you're dependent. Doesn't mean they can always come out, especially in South Florida, which is notorious. Once you start making a little too much, they might go look for somebody younger and cheaper. Let's get the younger, newer, cheaper model and see what we can get and work that one, and then work until that one will work until what? Well, let's get another younger one and cheaper one. Just keep going until it keeps going over. So being an independent private physician is difficult. What I did, I actually joined. We have a IPA, so an Independent Physicians Association in the state of Florida for orthopedics, and I joined the group about 13 years ago because negotiating contracts with insurance companies as a sole practitioner at that time was terrible. Today it's got to be impossible, but I sat down, I'll never forget, I sat down with the CEO of the company at the time, and we had our NDAs, and he had his insurance contracts in front of him. I had mine in front of me. So I signed the paperwork. He hands over the insurance contracts. I look at the contracts and I go, oh, okay, so where do I sign? I'm not even going to show you mine. You don't need to see mine. And I don't care what your management fee is because I'm still going to make so much more with your contracting system versus whatever I had. It wasn't even worth it. And so it's not an employed model, but it's a way to keep we're in a large independent physician group where each practice runs its own way. Everybody does their own thing, but we all bill under one tax ID. And it's, pretty much done to negotiate the best rates because as we know, like you said early on, rates are going down. My rent in my office is still going up. My staff, their salaries aren't going down. Yeah, we got to keep them up. We have, they need to be able to earn a good wage. We have to keep on top of it, and insurance and everything. All that goes up, but the insurance companies and everybody just want to keep cutting down. So it's quite a fight.
What happens to patient access through the lens of orthopedics if everybody's employed? What would that be like?
Well, if everybody's employed, if we had a strictly everybody employed model, it would be almost a quota system where I think you're in the office, they tell you, here's your schedule of patients for the day. And because there's really no incentive for them to see more because you're an employee, you see your patients and then you go. And at the end of the day, you don't need to keep adding on because For them, what's the incentive of seeing more?
Right.
There isn't. It just means I have to do more notes, work harder, but for what? I mean, I hate to say it, at the end of the day, it's about reimbursement getting paid, but money goes, makes the world go round, you know. And, physicians, we have houses, mortgages, everything. A lot of, especially young physicians, have a lot of debt coming out of residency and fellowship. There's tons of debt that needs to be paid off that a lot of people don't even understand.
That hits back at that misalignment of incentives. That I'm not a physician, obviously, but that's not why physicians go to medical school to hit a minimum number of patients in a day and go home. It's to help people.
Yeah. And you want to help
Same.
as many as you can, but when you have so much, when it doesn't matter what you do, and you kind of get skewed. Like for me, I don't mind seeing as many patients as I can because I know that if they don't see me today, they're going to have to wait 2 or 3 more weeks to see me.
Yeah.
A lot of the big healthcare systems, well, that's 3, 4 months for follow, because they'll put in a certain amount and that's it. There's no extras, there's no double booking, there's no overbooking. This is what we have on our schedule. If everybody shows up, great. If everybody doesn't show up, it happens. But if you're employed, it doesn't matter if they all show up or if they all don't show up. Yeah, as long as you're there, sitting there waiting, it works.
And I'm in the more southern part of the county than you, Dr. Gorin, Coral Gables. So you can guess the health system. It's about 8 months to get a primary care visit right
Yeah,
now. You know who I'm talking about.
yeah, the big pineapple.
Oh yeah, that's the one. Love them, but they're slow. A
Yeah,
little
well,
slow.
yeah, but that's what it is, and part of the other issue that we have is some of that I would say it's on them, but the other is the lack of physicians across the country. There just aren't enough physicians as there is because that's another problem. I saw a statistic recently in orthopedics. I think the next couple of years we're looking at like 5,000 physician shortage in just orthopedics, and that's because the older generation is getting older, and a lot of those physicians, baby boomers, is a big generation are retiring, and there's just not enough medical. There's a lot of medical schools that have popped up, but there's not enough residency positions to fill it. So, and that's a whole nother issue when it comes with healthcare is how do you fund, who funds the residency positions? It's typically Medicare that funds it. And so opening up the residency is a whole nother thought, or even expanding residency.
Yeah, you. I'm glad you mentioned that because no news that I've seen on the TV or even in the normal spots online that isn't like a Becker's Healthcare. We are rolling off a cliff as we speak
Yeah.
in terms of number of physicians of any specialty versus the number of patients, especially with the patients that are getting older and needing more care. Are alarm bells ringing with your academies, with your colleagues? Like, are people talking about this? Because we patient access is kind of a catch-all term at this point. Some of it's applicable, some of it's not. But I'm waiting 8 months for a primary care visit.
Yeah.
Maybe I could find another physician, but what happens when you're waiting 8 months for a broken leg?
Yeah. And I mean, even in my office, it's happened where I've had patients. I had them yesterday. It took them because of a referral issue and just being able to get on my schedule and people not knowing how to talk and explain what's going on. This poor lady broke her elbow in December and didn't come into my office till yesterday. And she
Oh,
was, the bigger issue, has dementia. She's
mm,
not really with it and shows up looking at an x-ray and the caregiver from her caregiver manager was like, look, we tried to get in the last few weeks, we just couldn't get in. And for whatever reason, and it just gets delayed. And we're a small 2-man practice. So, I've sent patients to the university and I know even there, I always been tell patients, you're going to be waiting 3 or 4 months to get funded because how they work it. They're not going to overload their staff with patients.
well, I'll be curious to see. I mean, I've got my feelers out when this is starting to be reported on your cable news networks, more broadly online. It's going to take systemic change to open up more residency spots, get more people interested in becoming physicians. Because that's the other half of this is that prior to COVID, it was all technology driving burnout. When you look at the surveys, it still does.
Yeah.
But now it's even, I think, might be even tougher to solve for. It's staffing, lack of support staff, too many administrative tasks. I have other physicians on the show with kids, and they're actively steering their children away from going into medicine.
I did that.
Like, do anything but become a doctor.
I have three daughters, and all three of them, I told them, you can do anything else but medicine. And it's not because of the medical side. And so
Right.
I have students that rotate in my office, like residents and fellows. I mean, residents and fellows have already bought in, but I've had students, I'm in college, and I say, look, if you want to do it, you better love it, because it's not what you think it's going to be. And I get very honest with them in my office because I want them to understand what they're getting into. So I'll also have them sit with me when I'm doing a peer-to-peer conference call. I'll have them see when we're denied issues, because you don't learn that in medical school. You don't learn in residency. You don't understand the true side. A lot of kids think it's Grey's Anatomy or ER, that what you see, and it's not. It's a completely
Yeah.
different world, and you're never going to learn that. It's always tell them, look, I got to deal with this insurance plan because I can't do surgery for this kid because he wants to go play football again next year. But the insurance plan says not a position with the plan. So that's the problem. So they don't teach that in residence.
I've heard this said about writing a book that it better be more painful for you to keep that book inside your head, whatever it is you want to say. It better be more painful to keep it in your head than to go through the pain of actually writing the book, editing the book, finding the publisher, doing all the stuff that's associated with finally writing that book. Sounds like medicine's kind of the same.
It is. It's become painful. It's become painful. And like I said, not the medical side. I still love the taking care of patients, helping people with their issues. Obviously, the surgical side. That's the fun stuff. That's why I always tell the students, like, if you really love that part, go for it. But realize there's a whole other side, administrative side. Like you said, support staff. It's so
Yeah.
difficult to find support staff today. Or many years ago, you could find people anywhere. But nowadays, especially with things online, certain apps that are out there, people would rather become influencers or try to become an influencer, and you can't find people that would normally work in offices, which I still think is a great position for most people, because it's almost a 9 to 5 job, because you don't have to worry about working on weekend or late
Sure.
evening. That's still gonna we do as physicians, is a whole other part. But if your support staff, you come in, show up, yeah, it's tough. I'll never say it's easy, but it could be a very fruitful position.
And I've heard this from some of the more influential folks that like oversee ASCs across the country, that they have a challenge, and I'm sure you have the same challenge, that the hospital could potentially pay you more than what I could pay you for the same work. Not saying that's true for you in your practice, but there's always the threat of big bad health system paying just a little bit more. But you miss out on a lot of the culture, and culture is what really drives retaining staff, being able to hire new staff to the degree it's possible. Do you have any pro tips for listeners out there on having great culture in your practice?
I think it's in your practice. You have to keep your finger on the pulse of the staff. I think you can't have doctors here, staff there. I think you really have to intermingle your staff, your management, everybody. Work as a team, but understand there is a hierarchy. It's not everybody's at the same level. But there's enough respect, mutual respect, and people understand their positions. It's still good to have a good, warm environment. We're very lucky. We have a great office staff, and patients are always telling me how wonderful my check-in girl is and the checkout person is, and this one did a great job. It's really nice to hear it from people, because we're so used to hearing like, oh, I gotta go see this doctor. It's terrible. And then you wait and go up front, didn't even look at me, and she was rude, all these terrible things. So it's tough to find a good mix to get to work. But once you have a great culture in the office, the patients feel it, and they get it, and they're happy to come back. I have many times I've had patients who want to come back just because they want to come back, and I go, well, can't. I'd love to give you time, but my time costs my office, so I need to know if there's something hurts. Everybody has back pain. Just tell me a back pain.
Yeah, right. That's high praise. That's really high praise.
Yeah. And it's tough. And then when you're in a corporate environment, the corporate the staff could be good, but the management, It's all about the numbers, and most of the management companies, are hospitals, hospital systems. All they care about is the bottom line. One of the big fights that I had years ago with one of our hospitals was that nurses on the floor were telling me, look, we need more nurses. We get more nurses. And the hospitals were like, no, we can't get them. And the nursing ratio was really high. And at the time, I was working on an MBA and we happened to look at the financials for this one hospital in our area because we looked at their national system and then, oh, let's look at what's going on locally. And we saw that that company, the local hospital, had made a profit of over 80 million. And so we were on a medical exec meeting, and I said to the CEO at the time, I go, look, don't you think maybe we can invest 1 to 2 of your profit in just nursing? And that will make patients' experiences better. People will be much happier, that you'll have better nurses because they're not going to be overworked and overburdened with all the extra minutia that they have to deal with in charting, because half the time they spend charting, not even taking care of the patient. And the answer was, let's talk about this later. Didn't like that I had found out that they made all this, but it was out there. It's a publicly traded company. So the data was out there. There's nobody to look at it. So when he got called out on it, he wasn't too loud. But that's the problem. They're not willing to invest in the culture of the system.
Yeah, and pivoting a little bit into investing into culture or even investing into your own health outcomes, I want to shift this a little bit towards patient accountability. We talked about this before we started to record, that for better or worse, kind of the American healthcare consumer, and more broadly than just America too, but something's wrong, I go to the doctor and they fix it.
Mm-hmm.
But maybe not taking into account lifestyle choices, diets, things that can give you the best chance for the best possible outcome in a scenario. I know you had a couple of thoughts on that.
Yeah. So, I often have these conversations with patients because it's important. And we need to change the culture. We need to go person by person. I don't often talk about, diet and the regular general health because it's not my field. And I do have an overweight patient. I often tell them, look, it would be better if you weighed less, it would be better for your joints. But one of my biggest treatment programs is physical therapy and exercise. That's when I talk about every patient. I'm a huge referral source for therapy because I think if we get patients moving their bodies, they'll feel better. And a lot of times patients will say, oh, I don't believe in therapy. And then I have to go into my discussion of, look, therapy is going to work. It's going to do this, the A, B, and C. They're going to teach you a program. Now it's on you to do the program, right? If you want to get better, you have to do the work. If you don't do the work, you'll never get better. Just like when you tell your kids they have to do their homework. If not, they're not going to pass. Not going to work. I use that line. Another line I use with patients is, look, so if you only go to therapy once or twice a week and you don't do anything at home, this is not going to get better. It's like saying to your dentist, I brush my teeth twice a week. Yeah, your mouth is full of cavities, right? But I brush my teeth twice a week. It's not enough. You need to do more. You have to be accountable to yourself. And I have that discussion with pretty much every single one of my patients that I send off for therapy. Even the ones that don't want to go there, they come back and they go, you know what? I'm so much better. And I've been doing the exercising. And sometimes I've had patients who were very reticent to go, and they come back and, you know what, I should have listened to you the first time. Because I am feeling better. And I am. And then typically my last visit is, now you know what you need to do. You know what's going to keep you better, whether it's your knee, your back, your shoulder. You have to keep doing what you were doing. And listen to this. If all of a sudden your pain starts coming back and you realize, you know what, I haven't exercised, I haven't moved, I haven't done anything in a while, maybe I should go back to doing this exercise to see how my body responds. So oftentimes I have to tell patients, look, you don't even need to come back to see me. You know what you need to do. You know how to take care of yourself because we've been through the process. And so they're happy to hear that. And then a lot of times I have patients, and they'll come back for a totally separate issue and say, yeah, I did the other exercises and I feel great. I've been walking, I've been moving, and it really helps. And they feel much better about it. Rather than you just throwing them a pill and saying, here you go, you're fine. Or just saying, look, let's take you to surgery and I'll figure it out and you'll figure it out after. This surgery is not always the fix.
Sure.
Hey,
yeah,
like you hear that, but
that's true. What I was going to say there is that it may be tough to get started working out,
yeah,
but you never regret having worked out.
Right.
Until you get to that 0.001 extreme end of the spectrum, there's literally no downside. Obviously, that's not medical advice. That's just personal
Well,
anecdote
I'll
from.
tell you, I never tell a patient to stop exercising. It doesn't matter what their health status is. There's always something that they can do. Whether it's if you can't go walk outside, walk in a pool. Get your body moving. Just offload the weight. If you know how to swim, you can go swimming. If you get on a treadmill, get on a treadmill. I mean, if you're bedridden, of course not. If you're in a wheelchair, but even in wheelchairs, there's a lot of exercises you can do with your arms.
Sure.
If there's too much pain for your walk, like I said, get to the pool. There's a lot of different ways to do it. Patients need to also be proactive because we can't fix everything. Oftentimes patients ask me, isn't there just something you can do that I can get fixed? And I go, look, if this was the era of Star Trek and I could take a magic wand and wave it up and down and you're fixed, great. But we don't live in Star Trek. We live in today. So you got to do the work.
This is maybe a little bit off topic, but we are kind of hitting at a Star Trek based world or a Star Trek based reality with some of these GLP-1s. I know that's probably not a conversation you have with a ton of patients based on your specialty. Do you have any thoughts on the Ozempics and the Mounjaros of the world?
So, it is, like you said, it's brand new. The discussion I have from the little knowledge that I know about those is, especially from an orthopedic standpoint, it's a big concern how much people are using that. Even if they need to lose 10, 15 pounds, they decided to do it, which makes no sense to me. But the problem with those GLP-1s, they're great at losing fat, but you also lose muscle and
Right.
also bone. So from an orthopedic standpoint, it's not a good thing because it makes it even tougher. So if people don't listen, or they go to some clinic to get their shots and aren't really educated properly, and they just take the shots and they just eat less and don't exercise, and especially women who already have osteopenia, they become osteoporotic. And then we talk about more fractures. They could have compression fractures in the spine. They can have hip fractures because, oh yeah, I lost a lot of weight, but yeah, you also lost muscle and bone mass. Those people that are on these inhibitors need to definitely do weight-based exercise at least 2 to 3 times a week to help stave off the loss of muscle and bone.
Some of the headlines in recent weeks, even just this week, as you pointed out, they will help you lose fat. They will help you, maybe not help you lose muscle. They do have people losing muscle and bone loss. People seem to have forgotten your heart is a muscle as well. And this is recent research. But I'm hopeful, or I hope for the people using them, that it isn't some terrible deal with the devil. That yes, you've lost a bunch of fat, but you also lost a bunch of bone mass,
Yeah.
and then heart muscle tissue as well. I think that's really scary to consider.
Oh yeah. Yeah. So I think if you're too quick to start jumping on the bandwagon, it looks straight. You have to wait and see. Problem is they come out so quick and people are so happy to find a quick alternative. I think that's the problem is finding a quick alternative, not very quick.
Yeah, yeah. I mean, not to put too fine a point on it, but move, lift a weight.
Well,
You can do it.
simplest thing to do, move, get a walk and get moving. You don't have to be a gym rat. You don't have to go out and run a 10K, but just walk. Get up and move. Get your heart rate up. You can do a walking. You don't have to do it running. You don't have to get on a bike. You can do a walking. Just go a little bit quicker than your normal, and you'll get it.
Yeah. And then in a even more tangible Star Trek example, I like that theme. AI in healthcare has been the hottest topic for the last almost 18 or so months. 18 months ago, we were talking about what we might be getting soon, and now we're starting to see some of the things that are in place. You have LLMs inside of EHRs now. Good or bad, I think that remains to be seen as well in terms of physician time using them. But as an orthopedic surgeon, what are some of the AI technologies that you're seeing? Are any of them cool? Do you like where we're headed? I mean, just kind of open ended there, Dr. Gorin.
So some of the AI stuff that we're seeing, I haven't seen it in my office yet, but I've seen some cool stuff in the OR where we're using I don't know if it would be strictly AI, but definitely VR or VA, virtually augmented, where you can actually see where to put hip replacements and shoulder replacements, where you put these goggles in and you get a CT scan preoperatively, and you can see the proper alignment literally in front of your eyes. You can see the bones without all the muscles and everything around it, so you know exactly where to put the implant in, specifically for that patient in the proper position, which is most of the time we learn the way we learn is hands-on looking, but if we can peel away all these pieces of the onion and see everything, and then when we do the procedure, we get a little bit better fit, a little bit better position, just to give a better longevity. That's what we're seeing in orthopedics. In the office, I fear the EMR company that I'm going to in the future is going to have an AI component built in. The problem as a practitioner is you have to learn how to use it. And will it pick up appropriately? Will it give you the diagnosis that you need? Will it use, every physician is individual. We're not everybody. I treat patients one way. My partner treats patients another way. My buddies across the hall treat patients a different way. So the AI would need to learn how each of us works to understand how to put it through the process. If everything was simple cookbook, it'd be easy. AI would pick it up, it would say something, boom, there you go. But I don't see where that's going. Where it has helped me, is dealing with insurance companies, going back to the beginning, and writing letters to insurance companies. Where before, I'd sit there for 10 minutes just trying to figure out, what am I supposed to say? Why do I need to get this MRI on this patient? I've done all this stuff. Nowadays, I can put in any one of these generators and a nice long 2-3 page letter with reference material and everything is printed out. And then it's difficult for the insurance company to deny it because here it is, everything you asked for, plus references in medical literature. So we have data on our side. So it's difficult for them to disapprove of either an MRI or therapy or surgery.
That's kind of a live by the sword, die by the sword for the payer, because you better believe, and I know they're sending you LLM generated denial letters. Might as well feed them a little taste of their own medicine there.
Exactly, just get it right back. All they want is paperwork. That's what they're looking for. I mean, if you look a lot of the charting that they do, a lot of the charting is excessive, and it's just to meet the paperwork standards that they need. We have to do more. There's a lot of requisite things from the government that we need to click certain boxes. It's like, well, these quality care measures that Medicare's come out. They ask us to check blood pressures in the office. Well, if you're a primary care physician or cardiologist, that's great. Somebody comes to my office with that high blood pressure, I look at them and go, who's your primary? I don't know what to fit. Last time I treated hypertension was a long time ago. So I don't know what you're supposed to take for it. There's so many different medications today. But because of the way the government is, we have to check off the box, which adds more time and more headaches in the office. And those goalposts change. That always moves. They're never keeping it in line.
No, it's changing rapidly. I know you and I first got to work together in Meaningful Use Stage 1. And your colleagues here in South Florida that are pediatricians had a lot to ask me about why they would need to check the smoking status of a 4-year-old little girl. Yep. And that's a pretty valid question. But these quality measures are going to be out of your hands now soon to a degree with THA and TKA Pro PM, where you're actually surveying a patient ahead of the procedure and then again after the procedure, and you're going to be reliant on a patient to provide a survey. Not even about the quality of care, not even about how they said the procedure went, just sending in a survey at all.
Oh, yeah.
That again just seems so out of alignment with what medicine really needs to have happen, which at a baseline is reimburse providers, at an acceptable rate. But now you're going to get paid less, and you're going to be chasing surveys for procedures performed. I mean, this would be the time to rally folks to write their congressman or write a mean letter to CMS. It just seems crazy to me.
Yeah, because we have a hard enough time getting patients to fill out paperwork in the office, right? And then to ask them to fill out another survey, they just wouldn't even want to do it. And then they don't care. Because all they care about is, look, I want to get taken care of. It's like, well, we need you to do this because otherwise if you don't do it, then we won't get reimbursed or they'll cut our reimbursement. I'm like, well, that's not my issue. That's a you issue. Right. But they don't understand. They keep doing that. As time goes on, and then we're seeing this, with the reimbursements getting lower and lower, more physicians are dropping doing procedures. So why is it, I had a patient one time who said to me, Doc, why don't you give me some of that money that you're going to make on my knee replacement? What are you talking about? He said, yeah, I want some good money. You can make some good money. I go, well, let me ask you. Well, in all honesty, how much do you think I will get reimbursed for your knee replacement? I go, I'm not talking about the hospital. I go, how much do you think myself or my practice is going to get reimbursed for me doing this surgery? That's literally going to change your life. It's highly risky and everything. He goes, Doc, you're going to get paid like 10 grand for my knee replacement. I said, okay, for me to get 10 grand, probably need to do about 7 of your knees. You only have 2. I go, if I'm lucky with 7 of them, we'll get to the 10 grand. And he looks at me, he's shocked. I go, yeah. We don't get, the hospitals will get paid a lot. Then the hospitals will do everything they can to kick patients out of there after day 1 because they don't want to keep them in because they need to turn over their beds. And they realized through the pandemic, all these patients that were doing these elective knees were going home and they seem to have been recovering. But just keep doing that and not realizing that not everybody is meant to go. The ones that we were doing during the pandemic were a little bit healthier than the ones that all the ones that we did. So I've seen
Sure.
more issues ever since they started making this discharge patients on first effort. It's a whole nother issue.
Yeah.
So for that, I'd rather just do them at knee replacements and shoulder replacements at an outpatient surgery center because we have better care.
Right.
Hmm.
Right. I mean, that's the shining star in healthcare now is the ASC, where you have much better alignment of incentives. Although you can kind of debate that on some ends of it as well in terms of reimbursement.
Yeah. But we're able to get patients, do a quality approach and have a whole well-rounded system that we can set up beforehand. But when they go to the hospital, it's difficult for us to have the post-op reports already laid out because we have to wait for the case managers and then everyone in the hospital to do their part. Or we can get a lot of that stuff preoperatively in the surgery center.
Yeah. Well, Dr. Gordon, we've covered a lot of ground. Is there anything we glossed over or anything we want to circle back to?
No, I think we're pretty in depth with that.
Well, I've really enjoyed it. So before you go though, let listeners know where they can find you online. Are you big on any social medias?
Yeah, so I'm in all of them. Instagram, LinkedIn, and you can definitely find me on LinkedIn and go from there. That's probably the best way. Twitter, Facebook, uh, all the other stuff my kids are on.
Well, I'll track down all your profiles and get them added to the show notes so listeners can click through and give you a follow, give you a like.
Appreciate that.
And on behalf of the entire Doc Buddy team, I want to thank you for listening out there. Dr. Gordon, thank you very much for joining us today.
You're welcome. Thank you for having me.
Our pleasure. And be sure everybody subscribe to Apple Podcasts, Spotify, and YouTube, and we'll get you on the next episode of the Doc Buddy Journal. Take care.
Bye.